You're okay that we record this for training and monitoring purposes. And it really is for training and monitoring purposes. Training and monitoring. Yeah? You cool with that?
Yeah.
Yeah.
Good. Well, we got a recording, pause recording. We're all guns blazing. I hand you over to Anna Stokes, author and creator of the Courtyard Standard Operating Procedure.
Hi guys, how are you?
Hi Anna.
Hey.
You all right?
Yeah, good, thank you. How are you?
Yeah, good.
Enjoyed lockdown? Ready to get back to it?
Yeah.
Ready to be bored stiff and have your mind blown out your head?
Yeah, every day.
Right then, so we're just doing this, it's just basically a summary of the SOP we sent you this morning, just to highlight the important parts, just to help it absorb a little bit better for you. So basically, the reason why we've created this standard operating procedure is to create...
By the way, you can see our screen already, guys?
Yeah.
You got screen share? Sweet. So like we said, and I sort of summarized it as well. This is like a side piece to you reading it, and at any point in time, do pipe in. So there are no stupid questions.
Yeah.
So there will be lots of acronyms coming at you. I spoke to one of you a minute ago and you didn't know what, I just said SOP to Jess and she didn't know what it was yet. So okay, it's okay, all right? So we might be familiar with them because we've been reading them for 8 weeks, but you won't be. So stop us at any time, butt in, ask questions. Whatever questions you're asking are probably what other people will be thinking when they watch this video. All right?
Okay.
Yeah. All
right then. So the reasons we've created this SOP to meet the objectives, and what we want to do is we want to create a safe environment for our patients, provide a safe environment for our staff. We need to protect the patients and staff that are shielding or vulnerable. We need to prevent the transmission of COVID-19, and we need to protect our staff from the asymptomatic carriers. Create a safe and functional practice so we can provide dental treatment for our patients to maintain their oral health. This is to supplement our normal procedures, so it's not going to take over any of the normal policies that we have in place, but it's to supplement them and to make them better. Okay, we don't know whether these are going to be permanent or whether they're going to be temporary, but we're going to have to keep using them until we're told otherwise. Okay.
Yeah.
So the reason why we feel it's safe for you all to come to work, because we had a number of criteria we had to meet, and we've managed to meet those criteria. So the criteria we've met are, we've got the appropriate enhanced PPE, the appropriate practice staff risk assessments have been completed, appropriate policies have been updated, staff training will have been completed, and your concerns addressed in a few days. We've increased the facilities of hand hygiene, and also got notices up to inform patients how to do it. We've applied social distancing measures in the practice. We've organised the diary so it's now zoned, so we can now manage the non-AGP, AGP. We've got fallow periods introduced into the diary as well for the high-risk AGE procedures. I'll explain what AGE is in a minute. So most of our surgeries can be ventilated, so ventilation is going to be a big thing moving forward. And we now know what the appropriate fallow times are, and we know what the cross-infection measures are needed that we need to implement. So it is safe for the patient to attend the practice as restrictions have been eased from the government, and also individual risk assessments will be carried out for each patient prior to their appointment. So we feel now that we have met the CQC requirements of being safe, well-led, responsive, effective and caring. So lots of tick boxes. So regarding transmission, so in the past we're used to dealing with contact transmission, which is touch, and droplet transmission was the splatter that we can see. The thing we have to deal with now is the aerosol transmission, and that's invisible. It's less than 5 microns, and we can't see that. So that's what we're having to manage now. And we've also got to be aware that there's asymptomatic carriers. So 30% of the cases don't know they've got COVID. So we have to protect ourselves and presume that everyone that walks into our practice could potentially be an asymptomatic carrier of the disease. So the government released some alert levels in May, and we are currently in level 4 transitioning into level 3. So level 3 is when they reduce and relax the restrictions, which they've done, but they're still classing us as a level 4 at the moment. So we have to just be aware of that. But because they've released the guidelines, it's now safe for the patients to come and see us. So the terms we're going to be considering as AGP, as we know, as the aerosol generating procedures, the non-AGP aerosol generating procedures, but we've also got to factor in now the aerosol generated exposures. So they're classed as the AGE. So these are the natural exposures, which include contact transmission and both droplets and aerosol caused by coughing, sneezing, and exposure to respiratory droplets during expiration. These are unpredictable. Some patients may be at more risk of creating AGE than others. We've got hay fever season. There might be more like sneezing and coughing more. And also some treatments are more at risk of causing AGE than others. So you might have a patient that's more susceptible to gagging, for example. And of course, we've got the handpieces as well. Therefore, we need to risk assess. We need to pre-triage our patients, and we also need to risk assess every type of treatment that we do, so we know which diary zone that they're going in. This will determine which diary slot we need and also which level of PPE we need. So we've got an example of the form we're sending to all our patients, and we're going to be sending these to all our staff as well. So these pre-triage forms are for us to risk assess everyone prior to attending the practice and prior to you coming back to work as well. So we can just check, you know, the following things, your COVID status, but also see if you've got any concerns regarding coming back to work. A big thing that is now, which has been added, is the loss of taste and smell. 60% of patients or people might get a loss of taste and smell, and it's actually a more common symptom than the cough and the temperature. So this is our lovely table. This is how I've risk assessed every single appointment that we're going to be doing. So for example, an examination, low risk AGE, if you use no 3-in-1, but you've got to accept there's going to be a risk if you use a 3-in-1. So it's going to increase it. You can reduce the risk by using high volume suction, have your windows open, and avoid the use of the 3-in-1. All right. So, for example, radiographs, you can use extraoral rather than intraoral radiographs to reduce your risk. 3D scanning, you might decide to do that rather than taking impressions because you're going to be at less risk of triggering a gag reflex. So I'll let you, you've got a copy of this in the SOP, so I'll let you just have a little read through that on your own, because otherwise it'll take me ages to go through each point one by one because it's long. So basically with the amount of aerosol, it can be determined by the amount of time you've got the handpiece in your hand. For example, if a low risk would just be if it's just in your hand for 10 minutes, you're going to create less aerosol than if you're trying to section through a big bridge, which you're going to be creating a lot of aerosol doing that. We haven't got them yet, but we will be getting air purification units. So you've got a question, Kirsty?
I was just going to say, like some fillings that are quite small would be low if you were just to polish it afterward, like at the end, you know, just to check the occlusion. Would that be classed as a low or a moderate?
You'd be in an AGE. Anything that involves a handpiece, you'll be that'll be classed as a moderate to high AGE. So you'd be in your full PPE. Yeah. So, for example, if a patient comes in for a checkup and say, "Oh, I've just lost this little filling. Would you mind doing for me?" You're going to have to say no, because you're going to have to get your level 3 PPE on for that. But it might be worth saying to them, "I can't do it yet, but if you want, we can rebook you an appointment to come in for your filling, and you can have an ultrasonic clean at the same time, and then you can batch those treatments together."
The other thing that I was going to ask, can I just ask a question?
Yeah.
So obviously working as a therapist, sometimes a dentist, I need a dentist to come in to see him. I guess that's not anymore. I'm not allowed to get you in.
It will depend, I suppose, what it needs to. You need to try and avoid doing that.
Yeah.
Say
if I'm doing a filling,
that dentist is in an AGP treatment or not. If that dentist is all dressed up to the nines, you know, that might not be possible. but you might be able to do it if, you know, that dentist is in a non-AGP procedure. They just need to put the normal PP on to come in and have a look.
Yeah, so that's what I was going to say. So you could, so if I'm doing a filling and it turns into an exposure and I need some lead mix putting on, for instance, is that not a thing I can do anymore? Shall I just close it up and then send it on to the dentist?
If you're in the middle of filling and need that, you'd have to close it up, because the dentist, in order to come and see you, would have to put on the full PPE.
Yeah. Right. Okay, thanks.
So I think probably in situations like that, if there is a deep filling that we think there's risk of exposure, it should be booked in with a dentist rather than you.
Yeah. Cool. Yeah. Thank you.
So windows opening, as I said, will increase the ventilation, air circulation. And I've done a little table regarding the PPE. So in short, we've got level 2 PPE, which is our normal PPE, which you'll be wearing for low to moderate AGEs, which are things like examinations, anything that doesn't involve a handpiece, basically. So intraoral photographs, whitening, fits, things like that would just be in standard PPE. Hand scaling, that's just standard PPE as well, because that's just droplet and contact. You haven't got any risk of aerosol. But anything involving a handpiece or ultrasonic, any airflow or anything like that, that is classed as high risk. So then you'd be donning on your level 3 PPE. The eye protection must be worn at all times. So when you're in the surgery, you have to be wearing your visor or goggles, but visor is probably more recommended just to protect you from any sort of AGE. So we've got ways to reduce transmission, okay? Reduction in the production of the aerosol generation, reduction in the number of social contacts by social distancing, reduction in contact transmission, so we've got decontamination in the appropriate PPE, reduction in droplet transmission, that's like splatter, so appropriate PPE, decontamination, high volume suction, and reduction in the aerosol, air purification, ventilation, appropriate PPE, or high volume suction and rubber dam. Is that all right? Make sense?
Yep.
Yeah. Yeah. So we've had a little chat about alternative procedures to reduce AGE, and also we've got the additional, and then reduce the aerosol, rubber dam and high volume suction. There's also the respiratory hygiene measures to consider, you know, the catch it, bin it, kill it. So we've got notices around the practice, just to remind patients and staff about that. And just to note, the pre-mouth washing hasn't been advocated in the FGDP guidelines, just because of the lack of evidence. And the reason for it, I'll just explain, is COVID is a respiratory disease, okay? The mouthwash will help disinfect the oral cavity, but just for a few seconds, then it's going to reinfect. So it seems to be pretty pointless. There's very little evidence against that. And also you've got to consider the risks of if the patient's mouth washing and then spitting out, and then that increases the risk of the aerosol generation. So you've got to balance those risks.
That was going to be my other question. I know I've obviously seen along the way, some people have been mentioning that the patients aren't allowed to use the spittoon.
Yeah.
Is that
I think you've got to, I mean, you can't stop them from using it. Quite a lot of the things we use taste disgusting, but it's minimal. Yeah, they have to use it on a minimal basis.
Right. So even in like a non-AGP,
a non-AGP, I would probably try and avoid them to use it.
I bet his phone rings all the time. Right, so if I'm doing a hand scale, they're not allowed to rinse or spit.
I'd try and dissuade them from using it.
Ew. Yeah. Okay.
If you're only going to have, it's going to increase. You've got to think about the aerosol generation in those procedures, and you're keeping it to a minimum, doing a hand scale with suction, because you will be using the suction whilst you're doing the hand scaling. But as soon as that patient sits up and spits, you're then increasing your risk then, and obviously it's going to be quite a bloody procedure as well, and they won't just rinse once, will they? They'll rinse like 4 times.
Wow.
You know, because they do like rinse and rinse and rinse, don't they?
Yeah, yeah. I mean, the thing is, when we're telling people this, they're just going to have to understand, I guess.
Yeah,
it's not a rinse
all an
there.
education, and that's a good point.
Why? Not a rinse there. I'll just have to explain.
Yeah, it's a good point for us to make in the patient information leaflet, that just to inform the patients that, you know, they are going to be, you know, asked to not rinse after, you know, just to reduce the risk of the aerosol generation exposure, because it's a big thing, really. All right, so I've already touched on this, but the factors determining the AGE risk are the length of time of the AGP, the COVID status of the patient, the ventilation of the room, the rubber dam, and the high volume suction. So they're the big ones that will help to reduce the AGE. Okay.
And the ventilation, is that just window?
Open a window. Your door, during an AGE procedure, your door will be shut. You will have to keep your door shut because you don't want to risk the AGE going into the practice, but you can let it outside. It's fine. And we've actually got someone coming this afternoon to try and get all the windows to open more.
I was going to say, yeah, that one in your room just opens back.
Yeah.
So,
and obviously, this is where the air purification is going to come in, because when we get those units, we'll be able to work out the air change in the room. And they say 6 air changes, and then you can reduce the fallow time. So as long as you've got 6 air changes going on within that certain time, then you'll be able to reduce the fallow period. So the 60-minute that they're recommending now is just a guide, and there are ways you can reduce it. But we just thought for the moment, we're just going to keep it at 60 minutes, just on the safe side. Okay. So on Monday, we're resuming face-to-face dental care. So what we've decided, and a lot of other private dentists have decided, that at this time, due to factoring the alert level where we are and the fact that the restrictions have been brought in, level 4 is a severe risk level, but level 3 is a risk in the general population. So the fact that it doesn't really balance with the fact that the government have reduced the restrictions, but they've kept us at a level 4. The government wanted to reduce us to a level 3, and it was Chris Whitty that wanted to keep us at a level 4. So it doesn't really marry up. So because the restrictions have been lifted, we've got to presume that any day now we're going to be going into a phase 3. But we've also got to respect that if the alert level does go up and the restrictions, the lockdown is brought back, we will be going back a phase. So we will be reduced to what we can do again. All right. So the essential treatment is any treatment that ought to be provided to prevent deterioration of the patient's dental health. So the essential treatments we've included in that patients with emergency problems or other dental problems during the lockdown period that require urgent assessment and treatment, patients with treatment that is not completed prior to the lockdown. Obviously, we've got patients that have been wearing the temporaries for 3 months that have been leaking oral hygiene, that we've been able to maintain oral hygiene. So they're going to be a priority. Okay. And then patients that were due in for routine examinations and hygiene visits during the period of exposure, just to maintain their oral health. We can check for oral cancers, periodontal disease, etc. And then people who do orthodontic reviews. These are all things that if we leave these patients, then they've got an increased risk of mobility, needing more complicated treatment. So it basically puts more at risk of the patient having to come to the practice for more complicated treatment. So it is all about balancing that risk and benefit to the patient. So the changes we've made, we've been very busy. So we've introduced the social distancing. We've got designated waiting areas now. So we'll go through all of this with you on Friday when you come in. We've also developed a shift pattern, increased the working hours. We've got staff areas, change rooms and staff rooms, obviously, where we've got to respect the social distancing. So we're not all going to be able to sit and have lunch all together anymore. That's a big no-no. And then we've also got reduced patient workflow. So regarding the patient workflow, the patients are going to be triaged before they come into the practice at the door. So temperature will be taken, and they'll be asked about the COVID status before they're let in. If they've got any symptoms, if they've got high temperature, they'll be going back home and being asked to go and get themselves tested. So we've put notifications up about the hand and respiratory hygiene. We've got hand hygiene stations all around the practice now. And we've also got the respiratory hygiene posters. And then we've got remote consultations as well. So we've developed, I don't know whether you've seen any Marcus's webinars over the lockdown period, but there's quite a lot of development in the remote triaging and remote consultations. So we've got the ability now to consult patients and do a minor pre-assessment for those patients at home before they come to the practice. And if they've got any questions about any treatment as well, we can do video consultations with them. We've also zoned the diary. So this is how we've worked the zoning of the diary. So it all depends on the risk of the AGE. So we've got high risk, low risk, okay? And then we've initially, in the first week, we've created a 20-minute break between appointments. So we've got a little bit of time just to get our heads together, get ready for the next patient, just make sure we can respect the social distancing measures we need to at the practice as well regarding the patients. And then we've got the vulnerable and shielded at risk groups. So they're the people that are medically vulnerable. So we'll aim to see those at the beginning of a session, so they're less at risk of coming in contact with anyone. And these will all be detected in the actual pre-triaging. And also looking at patients' medical histories as well. So before the girls are booking appointments, they're looking at the patient's medical histories and determining where they think the patient will need to go.
And is the vulnerable category the people that were when before we shut down, like the over 70s still, or?
Yeah, I mean, you've got the ones that are high risk. You've got the ones that are extremely clinically vulnerable, the ones that sent the letter from the doctor saying that they can't go out and they're shielded. And then you've got the vulnerable category, so that's the over 70s pregnancy example, maybe people that have got controlled asthma, etc. So you probably would aim to see those at the beginning of a session.
Yeah.
Okay. And it'd be very special circumstances if we had to see someone with COVID. It would be an extreme emergency. Otherwise, they won't be coming. All right, but we've had to make facilities in case we do come across that circumstance. So they would be put in right at the end of the session and be treated in isolation. So obviously, we're individually risk assessing every patient. We've advised to delay all routine and elective treatment until the alert level decreases. Okay. So we're literally just going to be doing essential treatment until the alert level decreases. So we've also got to consider now about enhanced cross-infection. So these include PPE, the fallow times. We've got runner nurses now that are going to be doing quite a lot of work triaging the patients when they come in, helping the clinical nurses in surgery, etc. We've got a two-stage decontamination of surgery. So you've got to wipe with like a detergent and also wipe with a chlorine-based disinfectant as well. So the surgery floors now have to be cleaned after each session. So not just at the end of the day, it's after session. So it's after, at 2 o'clock when we finish, and then at 8 o'clock when we finish. And when you're doing an AGP procedure, the door has to be shut. The only time you'd open that door is if you had to take an X-ray. All right, but it'd be very, very quick. And we'll go through some scenarios in a minute how you'd manage that situation. And also you've got your window open as well, just to help with that. So I've made a list of step-by-step cleaning, which generally should be done anyway, but it's just a bit of a guide. And I think what we'll probably do is print it off and put it in the surgeries. So it's just a tick list of what you've got to do and what you've got to clean between each appointment. So it's literally a thorough, deep clean after every AGE procedure. All right, so I'll skip through that because it's quite a long list.
So, sorry, can I just ask, do you know, does the 60-minute fallow time start after you've done that?
So the 60-minute fallow time is when you put your handpiece down.
Down, right. Okay.
So that's when you can start timing the end of the AGP.
Right.
then I'll go through the situation of what will happen at the end. I've got a little bit of information about how you'll manage the situation.
Have we got any like little stop clocks or anything where we can like, you know, so you can time it?
No, we haven't. I think the clinical nurse probably will just make a mental note for the moment. Just look at the watch, or mind you, they can't look at the watch, but you know, when we're after we've doffed, or the runner nurse can make a note. We'll sort some situation out how we're going to time it. That's one thing I hadn't thought of, Kirsty.
Yeah, why we're here. That's why we're here.
That's why you're here. So the other thing we've got to consider now is our workwear. We at the practice we are quite good, but obviously we've got to wear the appropriate clothing at work and follow the guidance for laundering the workwear. The workwear should not be worn to the practice or outside the clinic after use. Clinicians and DCPs must keep clinical and normal clothing separated. Scrubs to be worn by all clinical staff. After dirty clinical wear should be transported in a separate washable bag, so you can use a pillowcase. So take your scrubs off, put them in a pillowcase, and then when you get home, you just put it in the washing machine. All right, clean them together. You shouldn't consume any food wearing your clinical clothes. So if you get hungry and you want something to eat, you must get changed into your normal clothes. Once you've taken your scrubs off, you'll need to put a new pair on. So you might need to bring 2 pairs with you to work. Okay. If you're doing a double shift, sorry, that's meant to say second, not section. The second set of clinical wear should be worn for the next session. Homeware should be kept in your locker, and you must not travel home in your clinical clothes, which we don't anyway. So on arriving home, clean down your car where your hands have been in contact and use hand sanitizer. Enter your home with minimal contact. Wipe door handles and light switches with disinfectant. Place all clothes and the pillowcase into the washing machine and wash at 60 degrees. Disinfect and wipe your phone. It's all contact. You need to think about what you've touched. And then wash hands in line with the hand hygiene protocol. Shower and then put clean clothes in, and then you're ready to hug
Touch your child.
everyone. So hand hygiene. We'll watch a little video in a minute. But when should this be done? So immediately before every episode of direct patient care, and include your forearms. Prior to putting on your PPE, after every activity or contact where your hands have become contaminated, after the removal of PPE, after quick equipment decontamination, after waste handling, at the end of every clinical session. Sorry, there's lots of spelling mistakes. To include forearms. Okay, so
basically every 3 seconds.
Yeah, basically we're all going to get OCD. We're going to be. That's if you haven't got it already.
Yeah. My hands are dry as anything.
So things to consider before hand washing: keeping nails short and clean when washing hands. Keep nails clean. Do not wear artificial nails and nail varnish. So obviously in the past we've not been that strict about nail varnish, but it's going to be infection control is going to be ever more important. And obviously we've got to follow the policies. If we don't follow the policies, we're in breach of the cross-infection control. So it's your decision. Remove all jewellery. A plain wedding band is acceptable. And then wash hands with medicated soap. Include forearms at the beginning and the end of every session. So I'll just watch the video, and then I think might be a little bit of an ad at the beginning of this. Okay, so the hand hygiene, obviously we've got to be aware when we need to clean our hands. It should be done immediately before every episode of direct patient care to include the forearms, prior to donning, after every activity or contact where the hands become contaminated, after the removal of PPE, after equipment decontamination, after waste handling, at the end of every clinical session to include forearms, not clinical scene, as I've written there. So steps to consider before hand washing: keep nails short and clean when washing hands, keep nails clean, do not wear artificial nails or nail varnish, Remove all jewellery. Plain wedding bands is acceptable. Wash hands and arms with medicated soap. Include forearms at the beginning of every session. So we're going to share the videos actually on the WhatsApp group. So we'll share the videos of the hand hygiene session and also the donning and the doffing. We'll be practicing the donning and doffing procedures on Friday anyway. We're going to do it in small teams and actually run through it with everyone. But what you've got to imagine when you're taking the important thing about when you're donning is obviously to make sure you're cleaning it, your hands are clean, but obviously you've got to make sure your mask's sealed. So the clinical staff could test each other's seal of the mask to just make sure that it's fitting properly around the face, make sure you can't see any gaps, make sure you can't feel any air escaping when you're breathing, for example. And then when doffing, obviously the technique there is you don't want to get contaminated. You're going to be covered. Imagine someone's covered you in paint and you've got to take everything off without getting paint on your hands. So you take the most contaminated item off first, and you'll be doing that in your surgery. Your gloves off first, and then your gown off and put it straight inside out and put it in the clinical waste. You then be leaving the surgery and going to our doffing area, which is in the downstairs staff room. So you'll still have your eye protection on and you'll still have your masks on. So in the doffing room, there's 2 boxes. You've got a box for your glasses and a box for your mask. We'll run through the logistics of it. But what you'll do, you'll clean your hands, take your visor off first, put it in your box. Clean your hands, then you take your mask off. Put your surgical mask in the clinical waste. Clean your hands and then take your other mask off. Your FP2, FP3 mask, which we're wearing on a sessional basis, and then you put that in your box. We're going to put some plastic bags in your box. So the plan is you'll take your FFP2 mask off and you'll put it in your bag. Clean your hands, and then you'll take that bag with you to the next AGP surgery, which will be in a different room that you did your last AGP in. Okay, I know it's difficult to get your head round, but we'll run through it on Friday.
So I assume, say, for instance, will I be going to a different surgery then, whilst mine's like, what's it called?
Well, so your surgery's in Fallow, you'll be using a different surgery. So in respect to each clinician who's doing an AGP session will have 2 surgeries. So you'll be doing an AGP session in one surgery and going to another surgery, doing another AGP, then leaving that one Fallow, then going to another surgery.
And how long do you have in between that? Half an hour?
We've given people at the moment a 20-minute gap.
Right. So 20 minutes, done off, wash up, go, and then over to your surgery.
Yeah. The other thing you've got to consider, which we'll go through later, is note writing, because you can't do your notes in your room anymore.
Right.
It blows your mind. I've been thinking. Pardon?
What about no, you can't do it at the time. So you can't use your keyboard to like dictate.
Like say once you get through to the other one.
To your nurse.
If you want to dictate your notes, you probably could.
Do you know to put in my like BPE and stuff like that?
Yeah, I mean things like that you can write your notes in your surgery, but what you don't want to be doing is writing your notes when the surgery's in the fallow time, because you're going to be in the aerosol. But you can write your notes. The keyboards are going to be covered, so you can write. The nurse can write and type on the keyboard over the cling film. All right.
Yeah, that's fine. I was just going to say, I was like, how am I going to remember it all?
yeah. No, that's fine. It's more like the conversation and things like that you'll have with the patients. But you know, after you've finished your session, you'll be going out of the room. We are looking at creating workstations for the clinicians, but it would probably be advisable for you to bring a laptop in so you can link up to your computer via TeamViewer and do your notes that way.
Right.
In a different area of the practice. But these are all logistics we're thinking of at the minute. We're setting up some workstations in the staff room, I think, for that social distancing. desks in the
Work.
staff room for note
Yeah.
writing. Yeah. So staff roles. We've got some additional another additional roles, but I've just like tried to break down what each role is going to be doing because it's going to become quite important. So reception, communication with the patients, email, phone, mobile messaging services used to arrange appointments, send out triage documents and necessary consent to patients via DocuSign, manage the diaries, excuse me, checking the toilets and communal areas for cleanliness, clean light switches, door handles, banisters that patients might touch. It is possible that might be done by the runner or buddy nurse, but we just need to see how it works when we're running through the scenarios on Friday. Clinical nurse, assist dentist during treatment, support the patient, and ensure surgery is cleaned and well stocked at the start of the session in accordance to cross-infection procedures. Cleaning of surgery post-treatment, low AGE risk, assist with keeping communal areas clean if available. Buddy nurse, runner nurse, greet patient on arrival, pre-triage and take temperature, observe patient performing hand hygiene, process x-rays during treatment and collect any needed stock during treatment, cleaning of surgeries after AGE appointments, escort patients out of practice after treatment, assist clinical nurse at the start and the end of the day. I'll explain that role in a bit, okay, about the x-rays and the stock. The decon nurse is going to be responsible for cleaning, inspecting instruments, keeping accurate logs of all equipment functionality in line with decontamination policies, management of waste and sharp bins. She's going to be the first point of contact and communication between the AGE surgeries and the runner nurse. So we've got a speaker facility now on all the phones. So if you need anything collecting from any of the rooms, you will contact the decon nurse and she will communicate with the runner nurse to come and get it for you. What you mustn't do whilst you're in the middle of an AGE procedure is open a cupboard or a drawer. If you do that, everything in that drawer needs to be discarded and disinfected. So organisation and preparation is going to be the key to this. And then obviously we've got to try and manage the traffic between the surgeries and 345 to the CBCT room. So I think if any patient's going to need a CPCT, to ring decon, and then they can communicate with the runner nurses just to stand in front of the other surgery doors so no one comes out of those rooms. Okay. The dentist obviously to check the treatment plan, ensure all the relevant documents have been read and signed, communicate with the patient regarding any questions that they might have regarding treatment, remote monitoring, remote consultations, and carry out the necessary dental treatment. So I should include therapists for that. Sorry, Kirsty. It was late at night when I wrote that.
You've given me a headache, so I dread to think what your headache's like. God.
So, patient journey. We're going to be pre-consulting and by phone or video all the patients prior to the appointments. So we're going to just check if they're having any problems and whether the appointment they have is relevant to what they need. Okay. The pre-triage forms, they'll be sent the questionnaire I showed you earlier, the medical history, and they also need to be confirmed if they're attending the practice alone. They can't obviously bring anyone with them unless we know it, because we need to make sure we can respect the social distancing. A mother with 4 kids, for example, won't be able to come because we can't respect the social distancing and the staff now can't look after children. So that's going to be a bit of a challenge. So
what about if obviously somebody underage needs a parent?
So that consent process would be carried out probably in the surgery social distancing with the parent before any AGE procedures commence, so the communication start, and then the parent would have to leave the room or accept the risk of the AGE. They'd probably have to sign a document saying that they're happy to accept the risk of being in the surgery during the time of the procedure, but it would be advised for them not to be in the room, to be elsewhere. All right. Wait outside, for example. So the patient's going to call us to let us know that they're on the way, so we can tell them whether they can come in to the practice. Only one patient allowed to enter the practice unless they've got prior approval. On arrival, they'll have the temperature and the COVID status checked. The coat should be left at reception. Hand hygiene, well, we might have to change that actually. We'll think about that on Friday. The coat should be left in the car or, in a different area. We don't want them to have to take the coats into the AGE room. So we might have to find a cloakroom for them to put the coats in. Designated waiting rooms and zones. They'll have the treatment done, then they'll perform hand hygiene, and then the patient will leave, and then all the appointments will be done remotely. So the patient will literally come out of your surgery and go out the front door. Appointment procedure. So before the patient has the appointment, all forms will be checked that they've been completed. The phone call of video consultation if they need to see if they need an AGP. If a patient has experienced any concerns and now needs a high-risk AGP appointment, consider rebooking, batching treatments together. For example, I said, if they've broken a filling and they need a composite, consider batching that with an ultrasonic clean at the same time. And then just check the patient's been booked in the appropriate risk, AGE risk, and just check the relevant PPs that needed for that appointment. So procedure before high-risk AGE. So this is when, if we're doing a high-risk AGE procedure, so the surgeries will be cleaned in accordance with cross-infection policies, the water lines will be purged, we'll get out the materials and equipment needed, which is very important, as we've discussed. Hand hygiene will be performed. You might want to do an initial assessment of the patient just to check that you've got everything out that you want to get out with, which is some normal standard PPE on. Then you'd take any x-rays, for example, and then you put on your PPE and get buddy to check the seal of the mask. Get patient surgery, we'll change that. So during the treatment, windows are open and door is closed. There's no need to pre-rinse, lack of evidence. Assess patients to ensure all equipment and materials needed have been prepared. If x-rays are needed, attempt to do these at the start of treatment or postpone to the end of treatment. Decontamination at the first point of contact to ring if you need anything. If x-rays are needed, open the door with a disinfectant wipe and stand 2 meters behind the direction beam, or go out if required. Door closed, take x-ray and then re-enter after exposure. Disinfect x-ray using 2 wipes. You'd have a wipe, one hand wipe and the other wipe it, and there's going to be a box outside your door to put the x-ray in for the runner to develop. So it'll be the runner nurse that develops the x-ray, not your clinical nurse. If any additional stock is needed, it'll be the runner nurse that will collect this. So you'll ring decon, then the decon will communicate with the runner nurse to get the stock that you need. No one enters the room during the AGE, and the doors and the cupboards must not be open once the AGP has commenced. All equipment needs to be disinfected or discarded in that drawer. And then afterwards, the patient will leave, put the instruments in a box. The clinicians will dispose of all sharps. Then the PPE is doffed in line with policies. Your gloves and gown removed, put in clinical waste, hand hygiene, leave your eye protection and masks on, as we discussed. Your clinical phones, the ones you take your photographs with, you clean those with the wipes and put them in your pocket, then go to the doffing area, remove your eye protection, remove mask, hand hygiene, remove your FP2 mask and place in plastic bag. Perform hygiene, clean your eyewear and your phone, and then you take your mask with you to your next AGE session. And then the room's left fallow for 60 minutes and you're not allowed to go in there. So that's why we're talking about a separate area for note writing.
We could do with like a little open close sign so nobody kind of goes in.
We've got do not enter signs in the room and the doors.
I was going to
when
say
that door's shut, it's do not enter. Okay. Yeah. So after the fallow period, the runner nurse puts on standard 2 PPE, which is standard PPE. The surgery is disinfected and the surgery is prepared for the next session. The floor is to be disinfected using a designated mop, not pop, and recommended cleaner. And then the disinfectant is discarded. The mop head must be rinsed in and left to soak in the disinfectant, a clean disinfectant solution. So other considerations that we need to take are the changes in the rhesus guidelines. So CPR's guidelines have changed. So you no longer now listen for the breath of the patient. So you no longer put your head near the patient to check their breathing. You just basically cover the patient's mouth with a bib or towel, and you commence CPR straight away after alerting the necessary authorities, and get your defib, follow the medical procedure. All right, but don't check for breaths anymore. The other thing, just to let you know, if we have a fire in the building, social distancing doesn't apply, but obviously you need to be aware and follow hand sanitizing measures. Okay. Because you need to get out. We've got remote consultations, so the facilities we've got for that is an app called SmileMate and Zoom, which we'll go through with you. But obviously, if you're using any remote consultations, you need to make sure you follow the GDC policies. Data protection, patient confidentiality, record keeping and consent are very important. All right. So for note writing, you must not enter the surgery after an AGP for 1 hour. Notes must be done in a designated zone, so bring a laptop, and social distancing must be respected in those working areas. Notes can be done at home with TeamViewer as well. The other thing I just wanted to talk to you about, track and trace. That's a new thing that's come out with the government. So basically, it is advisable to record anyone that you come in contact with for more than 15 minutes. So if you develop symptoms of any high temperature, continuous cough, loss of taste or smell, and that's you or anyone in your household. So if you live with someone who develops symptoms, you've got to self-isolate. The member of your household with symptoms will go and get tested. If that test comes back negative, you can come back to work. If it comes back positive, you need to self-isolate for 14 days and you'll be on statutory sick pay. You understand? Yeah. So if you do develop symptoms, do not come to work. And if you develop symptoms at work, you will be sent home. You need to go and get tested. If your test is positive, all members you've come into contact with, including your colleagues, will need to get tested, or you'll need to be isolated. You'll need to isolate for 7 days until symptoms have gone. Okay. If negative, you wait for the symptoms to go away and then you return to work. Do you understand what I mean by that? So if you've got a positive test, you need to self-isolate for 7 days minimum, or until your symptoms have gone. So what if a patient develops symptoms after visiting us? So social distancing PPE measures will mean that we will not need to self-isolate or get tested unless we develop symptoms. Okay? So how do you arrange a test? So basically you visit the NHS website or gov.uk. I believe that there is a driving centre now at Greenhead College where you can drive through and get tested, but that might change. But basically you apply for one through the government website. And the other thing that's really important is staff wellbeing. We will be improving communication. We will be undergoing regular risk assessments. But if you're concerned about anything, talk to us and let us know. We can put things right. We are going to be providing regular departmental meetings to discuss anything and to discuss what's working and what's not, so we can make changes. You got any questions?
There was one thing I was going to mention. Do you know when you're doing the APG treatment and all the materials are out on the side?
Yeah.
Is there like a box that they go in so that they're less contaminated, or do you, because there's not anything on your list about wiping them down or anything to put them back in?
Yeah, I talked to Rebecca about this, and I talked to her initially about getting a box and putting all the equipment in the box, but then we decided that in order to get those materials out, you're going to have to open the box, decontaminate the box, get your materials out, contaminate the materials anyway, put them on the side, use those materials, and then put them back in the box, so everything's still contaminated, so you'll still need to clean it all. So yeah. Those materials will be left on the side. It'll be your buddy nurse that will come and clean them all. So everything will be wiped. So you'll have 2 wipes in each hand, and it'll be a wipe system and then put away, because you won't be able to put the materials away.
Yeah. No, thank.
Yeah, there's a lot to take in, isn't there?
Yeah.
It's a lot to take in.
It's new for all of us.
To be honest, it'll go in more when we do it, because obviously you try and figure it out, and then you try and put it into a scenario, and then you try and figure that scenario out on each person. But it's just going to take time, isn't it? I mean, we know our general cross-infection policies, but it's hyped up. So
yeah, it's hyped up, and also that's why when we go back, we're just keeping everything nice and slow, so we can
get your head around it, isn't it?
And get our heads around it, just making sure the flow around the practice works, because obviously.
Do we have to wear, like, you know, obviously you go into the like shops and stuff and people are wearing masks and general like things now. Do we have to do that if we're walking around the practice? No.
The only reason you'd need to do that is if you can't social distance.
Yeah, right, that's fine. I just wanted to check. I didn't know if if I got caught without one or something. So.
No, it's not advocated.
Yeah.
All right.
Right.
Yeah, Marcus's turn.
Thanks, Anna.
Bye.
See you Friday.
See you Friday.
So well done to Anna and all the hard work she's put in there.
I know, yeah.
We are all extremely sleep deprived at the minute. Unbelievable.
That's a big document.
So mine, I'm going to change content a little bit and just talk about some different things. And as ever, I don't have a checklist here, so I'll get rid of this. I might even stop the screen share. Still awake? Now I can see you properly.
There's nothing on there.
No, you can see my face, yeah? I don't have slides. I just want faces. Right. So, segging in neatly to where Anna left us was, there's no surprise, things are going to take longer, all right? So instead of resist this, particularly for the first few weeks, but even beyond that, we are embracing slow dentistry, all right? So we understand that it's not going to be quite as efficient and quite as profitable as it was before, but that's what our COVID business interruption loan is for, all right, amongst other things. It's to give us some breathing space, let's figure things out, let's get up to speed, and when we're ready to, the way we're switching surgeries will allow the clinicians to be efficient, all right? But there's no rush to get there, is the point, all right? So and it's been very helpful in making me understand that these things should be done, in a little stepwise to avoid the stress or panicking. So we're going to take it nice and easy, all right? So we've got a new business model, basically, everything's going to work a little bit differently. In terms of who's going to pay for the PPE, if you were listening to people out there in the forums, there are people who are making the clinicians pay for it and the associates pay for it by reducing their thing. We're not doing that. There are people who are asking the patients to pay for it, and I'm committed at this time not to ask our existing patients to do that. When we know what the business model looks like, then we might have to charge differently moving forward, but I don't want to do it to people who are already with us, if possible. And bottom line, guys, is that as you've seen, this is our opportunity to build a dental practice that works for us, right? And that isn't just the clinical bits that we've just seen here, but you remember how we used to work. It's pretty flat out, right? So that isn't possible now. So let's just build a different way. Little things which I don't know if Anna mentioned, but a 6-hour shift is great, but I don't know about you, but we can't drink coffee in that time period, and you can't eat. So therefore, we will be implementing a coffee or tea break, okay? After a 3-hour, and a wee. If you're going to be in if you're doing an AGE, so sensible things, all right? So that's the point as well. Things like that. So as it builds, let's all have feedback and build within reason a kind of practice that works for us first and foremost and for our patients, and then we can continue doing that moving forward, all right? Because what I've said in some of the lectures and stuff is that this is our single opportunity to rebuild our business, isn't it? So let's do it for how we want to as well. So another challenge we're going to have is what I call onboarding. So if you remember, onboarding is sort of where in IT, for example, they have to teach you how things happen, all right? So we'll have to re-onboard our patients a bit, won't we? There are lots of changes that they will have to get used to. I have already sent my first email out, but there'll be more to come. And as ever, the reason we're training you in this format is because it takes 7 bits of information to land in your brain before it sticks, right? So same with you guys. So we will be telling them about social distancing, we'll be telling them about PPE, we'll be telling them that things are going to take longer, Okay, and our best excuse for everything we're doing is COVID. All right, so you need to remind them when anything's happening. COVID. Why can't you call a practice? So do you know about our new incoming communication system?
Yeah, with the smile, mate. Is it?
Yeah, no, more than that. So our worry was that, let's just imagine that on the 8th of June our phones are on. What would that look like? It would be revolting. Okay, so that would be a mistake and that would be stupid. So I decided that that was the end of incoming communications in that format. So we've re-recorded a message that says something to, let me dig it up. Might even be here. Welcome to the Courtyard. Following the coronavirus pandemic, excuse for everything, we have made the decision to change the way we manage incoming communications. We would ask that wherever possible you make initial contact via our email on info@courtyardacademy.co.uk. This will allow the right member of our 5-person reception team to deal with your inquiry quickly and efficiently. If you do wish to leave a message, you are welcome to do so after the tone, clearly stating your full name and contact telephone number. Many thanks, and we look forward to assisting you. All right? What that means is we will never have to answer a phone on reception ever again in our lives. It's good, right? So it means that when that message comes through, whether they leave an answer machine or do an info, that the right person of our 5-person communication team can get to it. So if it's I want to rebook my appointment, fine. Then one of the reception ads or Gabs will deal with that. If it is, I'm a new inquiry to the practice, then TCO team will get on it. And the beautiful thing about that is that when they take that call for the very first time, they can manage that patient from end to end. All right. So they can book them in. They can book them in their own diary. They already have triaged them right through to when they come in to see me for clinical treatment. All right. So before we obviously had kind of different stops, didn't we? It would be picked up by the girls on reception. It will be booked in a TCO diary, and then So now the same TCO can pick it up and handle it all the way through, which is pretty cool. But it was invented so that we don't have to respond to patient issues on their terms while we're still on the phone. And it will create so many efficiencies. So, compare Mrs. Jones calling up saying, I want to reschedule my appointment, 5 to 10 minute phone call ensues, right? And in the meantime, 6 people can't get through, all right? Just rubbish. So that's a big change there, all right? So where were we, strictly speaking? We were on patient onboarding. So yeah, lots of new stuff. So that's one thing, the way patients are going to communicate with us. The second thing is how they're going to pass through the building. The third thing is lead times, okay? We always had challenging lead times, but now we have a good excuse for challenging lead times, all right? And the good news is, they're longer. And the good news is there's no one can do it quicker in the whole country, so it doesn't matter, all right? It is what it is. And even when we have to tell patients who were booked in for 10 veneer preps on the 27th of March that we can't see them until July, the good news is they are still at the front of that queue, and it's a growing queue. You know what I mean? So that's a good thing. So we can have, as ever, confidence that that's the way it is. Oh
my God, I just need to change that.
It's all right, my love. We've got a close team, haven't we? Yeah. So we all know, I think our methods of communication internally are getting better and better all the time. Yeah, you've seen the development of the little WhatsApp groups we're doing departmentally. What you're seeing now is we've got this new, this practice partner's grown while you've been away. All right. So she's getting bossier and chattier. Jokes aside, we've been working incredibly well together over the last 10 weeks, really, really hard. And slight yin and yang. I go one way, she pulls me back. It creates perfect tension. All right. So
perfect marriage, isn't it?
Perfect marriage. It's the same as any good marriage. So
same name.
We've got regular communication with all of our beautiful, highly skilled, close-knit team, and it's going to be embedded in the schedule. All right. So particularly in the first few weeks, but ongoing, we want to make sure there's opportunities to sort of catch up, make sure everyone's all right with things. All right. And the same thing is, it's a working plan. All right. It's our first plan. It's V1. All right. And we will modify it. And one thing I'm proud of with the shift system and stuff like that is we can tweak it. We can bolt more on. We can bolt other clinicians on who don't currently work here if they want to help us with the workload. It is not just our responsibility to handle that workload. Once the framework's in place, if other people want to come and do things, then it's going to be really easy for that to happen. All right. The practice is now effectively a hospital. Have you got that vision in your head now? Yeah. So anything that administratively happens off-site, and obviously the clinicians that are working there. So whatever it is, hospitals have close teams. All right. They have a comms team, they have a clinical team, they've got management, they've got owners, and we will resemble that. And when you're working, and then you go home and you rest at the end of your 6 hours, unless you're doing a back-to-back kind of thing. So that's the mental picture to paint in your head, and all the challenging things that Anna's discussed, we'll get used to, and it'll just become normal, and it's just one of my key phrases used to be a period of adaptation. Yeah. When we're going through that, it'll hurt our heads a bit, and we'll be like, oh, what do I do here? And then it'll sing. So some of the infrastructure of the AGE and non-AGE, I just wanted to show, I had to call Kirsty this morning and move one of hers along, because we found that there's only 2 scenarios that allow us to rotate surgeries the way we are. Before I go into that, not all practices are doing it like we are. Some are just accepting the fact that the clinician will have an hour he can't use his surgery in, and then he or she is going off to do different things, whether that would be a checkup or something in another room. But we've obviously taken the view that we're going to maximize the clinician's time and use the surgeries by rotating. Okay. And I think that's quite unique, and the way that we've got enough surgeries that we can do that. All right. And the way it works is if we have because we've got 5 rooms. So if we've got 2 clinicians doing AGEs, they each need another room each. Yeah. And it means we can only then have 1 more non-AGE going. Understood? That's scenario 1. The other one is that we have 1 clinician doing AGE, needs 2 rooms, and then we can have 3 non-AGEs going. Got it?
Yeah.
I did the maths pre-COVID and now, and it's about a 50% split of AGE and non-AGE. So that's the way we've maintained it now.
And we're also lucky we've got the waiting space.
And we're also lucky that we've got a massive grade 2 listed building where people can sit and not have social distancing challenges. And that's all mapped out. So the checkup model. Can I tell you about our checkup model? I've been busy breaking the status quo with our checkups. So for as long as we can remember, checkup and hygiene were kind of glued together. Yeah. Over our career, Kirsty, it become a hygiene-led appointment, didn't it? Yeah. And now for a couple of reasons, we just felt that I just tried to look at different ways of building it, because the assumption is if the clinician's covered in blues, then they should batching. We should really, really commit to batching, shouldn't we? And zoning. And if a clinician's doing one thing, they should just do that one thing. Get it off, move somewhere else, and mess with your head, right? So our checkup books, that's what we're doing. And therefore, if we could even batch the checkup effectively, then that would be helpful. So what we're coming up with is instead of having 2 checkups, we're going to have an annual review, all right? But that annual review is 20 minutes, not 10, okay? And that gives the clinician more time to do a really comprehensive conversation and consultation effectively with the patient. They're going to scan everyone into the iTero, and that is so that we can do better digital triage moving forward. So if a patient then calls up and says, I've broken my upper right 6, then all that needs to happen is that we bring up their thingy on screen and have a little look at them. Let me just help you visualize that. So the idea is that the value to the patient is the same because they're getting the same amount of minutes with everyone. In fact, they're getting more with you, aren't they, Kirsty?
Yeah. So 20-minute scan with the dentist, iTero, yeah, and
yeah.
comprehensive
check. And the fast forward of this is, as ever, in terms of onboarding, we're going to have to explain to our patients why we're doing this.
Yeah.
And why we're doing this is because...
that's yearly.
Yeah, that's yearly. It just minimises visits, and that is healthy. Yeah, I mean that is.
Will that include X-rays as well?
Yeah, of course it will. Yes,
yeah.
Everything that would ever happen. And as you know, NICE guidelines for a very long time have asked for a bespoke checkup period, and that an annual checkup recall period is acceptable.
Yeah.
And then we've got the data we need. Yeah, they still come in for their hygiene recall period as before. We will prescribe for the next 12 months effectively the recall period for their hygiene. So it's smart in that respect.
So they're still getting 2 30-minute hygiene?
Yeah, or whatever we prescribe. But instead of it being, and we all know that the way the checkup ended up being was 2 minutes in and out, poke the gums and leave, So this is, no, you're getting a proper one. And what I'm excited to find out is what that allows us to have conversations with our patients. All right. So watch this. See that?
Yeah.
That's my father-in-law, right? So let's just imagine, Martha.
I recognise those teeth.
I know. Poor him. He's not seen you for a long time either, Kirsty.
I bet you're loving it.
He might be loving it, but he won't be loving it when he comes back, will he? So
No.
let's just say he calls, he writes an email and says, I've broken this one. Well, he just says, my upper right 6 is sore. And Sarah Mann goes, okay, no problems. I'm going to go into my ITER and have a look for you. And we have a little look and go, oh my goodness, she's seen better days. All right, I'll bring it to Marcus or Alan's attention and they can look at your x-rays and come back with some suggestions. All right. So that's digital triage. So by uploading our entire patient base into the cloud in this manner, it allows us to manage them better moving forward. And what it's saying is that the current status quo is that someone comes in and says, I've broken my tooth or my tooth hurts. That's not helping me. Now I've got to send you home anyway. You know what I mean? So isn't it better if I can know these things in advance and plan so you come to the AGE appropriately? You with me? So it's really based on that fact that you coming in for, you know, a 5-10 minute checkup to tell me you have a problem to then be sent away again seems futile. So the idea is that we can help triage patients better when they call us.
Yeah, because even with just with a therapist, for instance, with your father-in-law, he would definitely need an ultrasonic. And if he rang up and said, "Oh, I've lost that filling on the upper right 5," then I would be able to basically batch that with a deep clean with a filling, without even having a prescription because I'm direct access. You got it. You've
either seen my lecture or you've got it in your head. So. Yeah, it's about the separation of AG and non-AG, about batching, and about if he did break this, then we're going to go, oh my God, need some ultrasonic, let's fix this. Actually, what are the other 2 teeth next to? Shall we do a quadrant dentistry plus a scale? Let's batch it, let's stabilize you, etc. All right. So it's about looking at that because it's what I call the end of ad hoc knee-jerk dentistry. Yeah. The NHS invented and that has just stopped. You know, no, we're not just going to fix it now. And in fact, we're not even going to plan it now. We're going to have a look at you and come up with some decisions. Yeah.
But by having that information as well, my nurse would be able to get out all the stuff I need, all my hand instruments, all my ultrasonics, all my filling stuff.
Yeah.
And then would you consent before they even came in? But what if they didn't have it? Would it be just scrap it?
Yeah. So the phrase we've given birth to is pre is key. Yeah. So imagine everything we're doing now is in advance. The estimates, the consent, the discussions, all the planning.
Even the prescription for me from you, that can also be done digitally, I guess.
You got it. So because doing things in advance is the way forward, you have to be organised. You know what I mean? And you can't just do it on a limb. Otherwise, when we do focus on the business model again, we need to make sure that we can do these things properly and in an organised fashion. Yeah. So what's great, Kirsty, is that you're buying into it. You know what I mean? Because we'll have to tell patients why what they're used to is changing, you know? And it's great just to say because of COVID, but we're saying, no, this will care for you better because we can then, you know, and none of our 1,500 patients have had these kind of scans for actual monitoring purposes. You know what I mean? They've had it because they're having treatment, but to have this as a record and for us to then be able to do this annually and do comparative things with it, it's just going to be cool. All right. It's what we want to do for ages. We've got the opportunity now, and I think they'll see the value. And I truly believe that when they come in and see this, they'll go, you know, to see to me again, Anna and Jess, for what will feel like a really, really comprehensive 20-minute examination. And you know, then even there and then,
making everyone do what we thought we should have done anyway.
Exactly. So you know, and in that consultation, they'll go, no, I do want those doing, and we'll go, okay, we'll batch it out. Okay, it might be in 6 months, it might be, you know, if it's not urgent, but let's plan it properly. And 20 minutes will let us do that. You know, yeah. So that's quite exciting. Let me get back to my notes, and we'll stop this share. But I'm glad you bought into that. So then what do we got? Yeah, that's really it. And what that understands is that therefore, because it's challenging fitting those bits of the jigsaw puzzle into the diary at the minute. So when we tell the patients that, look, because of the way we're doing things, it's kind of arbitrary when your annual checkup is. It's not connected to your hygiene appointments anymore. You with me? Yeah. So your hygiene appointments will be 6 months apart, but it doesn't matter if the checkup is in between, one end, doesn't matter at all. It's just in the year. You with me? And that will help them understand that, no, we're just looking at you, having a really good chat and planning for your next year of treatment and seeing how you are. All right. So yeah, we're really looking forward to sort of, like I say, giving that value back to the patients who stayed with us and kept us going and have been patient. It should really feel like they're getting value back, I think.
Yeah.
All right.
Yeah.
They're the majority of things from me on my little list. There'll be others, but do you have any questions?
No, I think I've asked mine throughout. I think, yeah, like I said, for me, it's just getting my head around the patient journey, really, and just being confident that obviously all my consents are all done, but that'll all be done prior to. What if, like, a patient can't do it?
They can. Yeah, I just spoke to, they can, but that will be receptionist's job to provide tech support when that's an issue. And even if we send it to their phone when they're with us, that's still okay. You know, a worst case scenario. But I just spoke to a patient, she's 76, she's got a phone, she's got an email, you know, everybody has it.
Yeah.
But they need to get it now because it's a digital world and you don't touch paper or pens anymore.
Yeah. I think for me, it'll just be when things pop up and I'm like, oh, I don't know what to do in this situation. So that'll be, so there'll always be someone in decom.
Yeah.
And there's a runner nurse that basically will be very tired.
Well, yeah, we haven't. I tried to flesh it out, and it hurt my head. But it may even be that that's why the runner suggests that she's dashing about. The buddy nurse suggests that it's actually attached to the AGE room. Yeah, and that you just have a dedicated buddy nurse while you're having that procedure. A bit like having a dirty nurse and you know.
Oh right, so you'll have a nurse, clinical nurse, who's basically aspirating and sorting materials.
And someone else who's just there for you. Yeah.
Right, and then there's someone in decom.
Yeah,
right.
So I tried to see if we could attach it directly, but we'll just see how it runs. But there is a high likelihood that it will feel like that.
And will there be two APG surgeries at one time, or
at a maximum? Yeah, yeah. So you know, it'll be very dedicated to that. Yeah.
Cool.
Okay. Yeah, you did well. You don't look too melted, do they?
I've got a real headache.
Yeah, mine was easy. It was nearly as long as Lord of the Rings.
Oh, Anna, it's horrible to you, isn't it?
No, that wasn't. It wasn't.
Oh, no, it was very informative. Thank you. And it's basically, it's put it into a document where we can understand it and.
Yeah, I've got one thing left to read, which is my distillation of the 60 pages that we're going to use to help reception and patients understand it effectively. So it reads like this. So it just explains that the aerosol generating procedures are now higher risk and require enhanced PPE and an hour clean down time between appointments. So this, what I'm about to read you, will probably go in some format into an email to patients, okay? Particularly just as we go into booking them. Here is our risk-benefit matrix per treatment type. Checkups, low risk, high benefit, get it booked. Hygiene sessions, these would need to be hand scaled to ensure they remain a non-AGE for the time being, low risk, high benefit. 3 new patient consultations, same, low risk, high benefit. And then we move on to what the girls are currently booking in, which is resolution of issues that presented during the pandemic that are causing pain or where no intervention may cause morbidity, more complex treatment being required, and oral health risks. So they are moderate risk, but high benefit, yeah? And all that element of treatment is at this stage deemed essential, okay? The next section of treatment that's also deemed essential is the completion of patients in treatment. So the long-term presence of temporary restorations on dentition and or implants create theoretical and practical risks to maintaining hygiene. These risks could cause detriment to the teeth or implants supporting them, and the increased risk of additional or repeat treatment as a result of this scenario makes it clear that completion of these patients be defined as essential treatment. Okay? So bottom line, if they're in treatment, it's no longer acceptable that we just leave them there, all right? Because it's bad for their health. So they are therefore essential treatment and they get booked in. The ones that we aren't booking in yet, well, until July the 1st, is commencements of elective treatments. Patients who wish to have elective treatment will be advised that this be postponed until one of the 2 following criteria are met. We move into stage 3, as per the SOP, whereupon the risk is lowered, or we have embedded new protocols and SOPs in such a way and appraised them that they minimise the risk to a quantifiable and acceptable level. And in the next bit, I mentioned the phrase, so where the patient meets our health and demographic risk assessment and is treated under our universal SOP, we would then see no barrier to treatment, all right? So what we're basically saying is, look, if they're young and we know we're good at it, then the risk is mitigated, yeah? And even though it's not a particularly essential treatment in those terms, we know that we've decreased or mitigated the risk to a level that we go, it's okay now. You with me? And that is a distillation of it. Any questions on that? Was it clearer or more confusing?
No, that's clear. So basically, we're sorting out the immediate stuff, and then eventually we'll be able to get into the elected.
Completely low risk stuff, book in. Broken stuff, book in because it's bad for their health. Stuff we're in the middle of, booking because it's bad for their health. New stuff, wait till we're a little bit more comfortable.
Yeah. I'm sure people are surely going to understand that.
It's logical. All right. We both appreciate your time and energy and being part of the training video. And you don't have to rewatch yourselves. That's the good news.
What I was going to just ask, can that document that Anna read out, can you email it me or so that I can print it out so I've got those tables?
We'll put it on WhatsApp.
Lovely.
They're all in the SOP anyway, but we'll put the summary on WhatsApp for people.
Yeah, just so that I can print it out and look at those tables.
I'll correct the spelling mistakes.
No need.
I probably didn't even notice.
Right. Well done, girls.
Bye, guys.
Thank you.